starting our program very shortly. We have a very eminent speakers with us, and we look forward for this program. So please, once you are done with your coffee, please come ahead and get seated.
Good morning. I can understand a very, very lazy Sunday morning, but you are going to be charged up today, having the best conference of the year. Good morning and very warm welcome to all the delegates to most awaited and sought after multi-speciality conference Educon 3 from the Bombay Seaworld Medical Association and Bombay Medical Union after a long wait of almost about 3 years. At the outset, I would like to congratulate all the family physicians who are present here that we have done a splendid job during the unprecedented times of corona pandemic. So I must congratulate all of us. On our association front, we pioneered webinars in place of physical CMEs to continue our commitment. Our webinar on Omicron virus got viral, exceeding about 50,000 viewership. The conference is very well designed to bring the latest in the medical world on a power-packed platform. It is specially designed to empower the primary care physicians and making them at par with the modern world. Through this conference, we also provide a platform for bonding between primary care physicians, specialty consultant physicians, corporate hospitals, and pharmaceutical companies. It has also given us an opportunity to recognize and appreciate our own talents and stalwarts. We have a basket full of lucky draws and prizes to appreciate your enthusiasm and to keep up the tempo till the end. Our souvenir is going to be, it will serve as an important document highlighting our speakers' expertise, their attachments and their contacts, along with their carry-on messages. I take this opportunity to thank today's chief guest, Dr. Tarang Gyanchandani, and our guest of honor, Dr. Anita Borges, the galaxy of speakers from the metro, and for accepting our invitation and serving an educational delight to this august audience. So let's begin, friends. May I call upon Dr. Sonia Kothari, the MCA today, and she will start the conference. Thank you.
Thank you, Dr. Anil Mehta, and warm welcome once again, everybody. I welcome you. Please begin our session today.
Here, I'm really thankful for Educon to have me speak on the current management of valvular heart disease. Unfortunately, in 15 minutes to cover all valvular heart diseases is a bit difficult. So I had a chat with our scientific chairman, and I'm going to restrict my talk to the current management of aortic stenosis because this is the hot topic. Although we have so many options now for non-interventional management of mitral regurgitation like mitra clips, for tricuspid regurgitation, things like the tricuspid clip and CAVIs, which are cable valves. But today we are going to restrict my talk to TAVIs and transcatheter aortic valve implantations. So while they're connecting, maybe I can just start with the introduction towards these valvular heart diseases. Now, as you all know that aortic stenosis, it's basically a disease of aging. The same way that as age increases, our blood pressure tends to increase and our GFR tends to reduce, in the same way, our aortic valve tends to get calcified and degenerated. So while over the age of 60, 1% of all adults will have aortic stenosis, the second you go beyond the age of 80, that number goes up to as high as 10%, which means 1 out of every 10 people who are above the age of 80 actually will develop aortic stenosis. Out of these, 3/4 of them will have symptomatic aortic stenosis. And the second you have symptomatic aortic stenosis, your life expectancy suddenly drops to 1 or 2 years. Now, as a 80-year-old today, our life expectancy should be nothing short of reaching at least 90, 95 or even 100, because now sky is the limit with the kind of medical advances we have. So in an 80-year-old, by no means should we deny a cure for this very curable disease of aortic stenosis. So, have we got the thing working? Okay. So, while we understand this, let's also talk about our options. That once you have aortic stenosis, at the age of 80, you always have two options. Either go in for an open heart surgery or the surgical aortic valve replacement, or we go in for TAVI. Now, in general, what is the risk of going for an open heart surgery? At a young age, below the age of 65, the risk of mortality when you go for an open aortic valve replacement is to the tune of 2 to 4%. Whereas when you undergo this same surgery at the age of 80 and above, that mortality crosses 10%. Meaning 1 out of 10 patients will not come off the table. And if we see morbidity, pneumonias, infections, atrial fibrillations, all this goes up to beyond 60%. It means that you're more likely that after the age of 75 or 80, if you undergo an open heart surgery, you're going to land up with some complication, some breathing difficulty, some kind of issue related to the surgery. My presentation has disappeared. Are all cases which we've done at Jaslok Hospital, and the kind of complexity which will come across is in all patients who were deemed inoperable by 1 or 2 surgeons. So our team works in that way, where we have a heart team meeting, and only if the surgeon denies the case which is what we call a high risk TAVI is when we go ahead. So I'm going to skip these slides which we did discuss about, but I just want to show this slide of Indian data, where in Indians, where we are 1.3 billion people, the incidence of aortic stenosis is to the tune of 918,000 patients. And symptomatic, like I said, are 3/4 of these. Half of those, if undergoes, are fit for candidates for surgery. The other half, that's around 280,000 people, are still candidates for TAVI. Those 280,000 patients, without this therapy, will just die within 1 or 2 years and die a miserable death. Can I have a pointer? So it's these patients who we are fighting for. And like I said, that now TAVI has come with such improved outcomes that it is a service which is available to everyone. So regardless of whether they are high risk, low risk, it is a therapy which can be used for any patient. All these trials basically showed that TAVI is equivalent or even better than surgery in some cases. And as you all expect, once you have a therapy which is so useful, the industry gets involved. And when we started out with only the Evolute R valve and the Evolute Pro, this is the basket of valves which are all available to us today in our city. Now, let's start with what is done in TAVI. Why is this option such an important option for us? Because of its simplicity. So the whole procedure is done in local anesthesia. We only take 2 extra accesses. That is, from the jugular we put on a pacing line, and we take femoral accesses for the arteries. This is the TAVI sheath going up. That is on the right and on the left hand side image. And as you all can see here, we take a wire and cross the aortic valve. If you all can see that thin wire which is going across the aortic valve, so the same image is on the cartoon on the right hand side. So once this happens, a balloon is taken and the TAVI, the original aortic valve is opened up. This is the device which comes up across the aortic arch, and this is the positioning of the device. Now the beauty of these devices are that if you go too deep or too shallow, they can be recaptured and repositioned. So in this particular situation, it was too deep, So it was recaptured, meaning we resheathed it, positioned it just 1 millimeter higher than what we wanted. So it is a 1 millimeter also makes a bit of a difference. And this is the result after the valve is deployed, where you have an excellent result, no gradients and no leakages. And the beauty is, the next day, this 88-year-old patient was walking around in the ICU with us like this. So the beauty of it is that the recovery time is nothing. Now, as compared to this, in surgery, you need general anesthesia. You're going to open the chest, get onto a bypass pump, and please understand that the bypass pump required for aortic valve replacement, the time is close to 2 hours as compared to a bypass surgery where the pump time is only 45 minutes. The valve is removed, a new valve is put in, and then the patient is sent to the ICU. Now, this is what happens on day 1 after the surgery. All our patients who are the surgical patients, you all can see the difference between the outcomes and the recovery of a surgical versus a TAVI patient. Now, the question should not be, which patient should I send for TAVI if they have aortic stenosis? There should be 2 questions in our mind. Every patient is a fit patient for TAVI, unless they are a high-risk TAVI, or if there is an actual preference for surgery for some reason, and this is what we are going to discuss today. It's very important that a multidisciplinary team discusses these options, and the patient's decision is also very important here. Otherwise, a patient who is not mentally fit for surgery will just never come off the ventilator. So, there are 2 factors which we take into account. Is the anatomy feasible for TAVI? And are the vascular accesses feasible? So that's basically it. And then there are some more differences we take in terms of how long the TAVI valve will last, what is the lifetime management of TAVI. Now, as per guidelines, this slide is really important because it tells us which patients are favorable and unfavorable for TAVI. So the favorable ones are with less calcium, whereas the unfavorable ones are where there's extensive leaflet calcium. LVOT calcium and pacemaker risks are one problem, and other things like horizontal aortas, no calcium on the valve because the valve is anchored on calcium. So what do you do? Now, I'm not going to show all cases where it is favorable, because those cases, it was the one I showed you all in how a TAVI is done. Those are the run-of-the-mill cases which we can do with our eyes closed. Now, when you have severe calcium is where the problem comes in. So if you all see on the right, the balloon that is expanding in this particular case will rupture. So you'll see the dye suddenly rupture and flow out. Because the valve is so calcified there, the balloon completely ruptured. So there's a spicule of calcium there, but still we went ahead, did the TAVI. So the calcified valve is still a case where you can, with certain amount of care, go ahead and do the TAVI, understanding the risks. The second is conduction defects. Some patients need a pacemaker, but there are predispositions, especially a RBBB will predispose you to requiring a pacemaker. Then another risk, another thing which was in the unfavorable category is very big valves or very small annuli. Are these also good or bad candidates for TAVI? And the answer is they can undergo a TAVI. Here you'll see a patient with a very large TAVI valve. You can see this is the largest valve available. And this was a balloon expandable valve. At the same time, this was a patient who needed a very, very small valve. In comparison, this side is a 34 valve, and on that side it's a 20 millimeter valve. So even the small and the large annuli can be done with excellent results. This was a case which has been accepted by at least 2 international communities. We are going to go to London and talk about this case, and we've already presented this case in TCT, US. Because this patient had, after an aortic dissection and an aneurysm, she developed an aortic regurgitation. Her valve was absolutely normal, and just the arch was replaced. But because her valve had been damaged during the surgery, she had a severe aortic regurg. So no calcium to speak of, and still we went ahead, did the TAVI, and this was one of its kind in iatrogenic acute aortic regurgitation. So one of the kind case which is not really documented in global literature. Now, this is a case where patient had a coronary problem. So even if you have a coronary issue, sometimes people think I can do a bypass and a valve replacement together. That's true, but this particular patient was inoperable. So what we did is we protected the right coronary artery. If you all can see, there's a stent down there, which is
2 minutes
undeployed.
remaining.
And only if required, you go in and open that stent up. So this was a horizontal aorta. You can see how this valve is lying flat. So even in a horizontal aorta with certain maneuvers, you can push the valve across and get the procedure done. Now the second thing, the first was the anatomical features, the second thing was the vascular problems. So even when you have vascular issues, like in this particular case, there was a dissection in that artery. You can see the haziness there. But after the TAVI, we put in a stent there and we got absolutely crystal clear normal flow, and the patient went back with a very good peripheral pulse. In case you can't go from the femorals, our team has expertise in even doing TAVIs from alternate accesses. This TAVI was done from the subclavian artery, that is from the axillary artery here. And while we did the TAVI, the patient had a lima to rima graft, which was getting kinked by the device. So we did the TAVI with the blood pressure on 50 or 60 systolic. And as soon as we were done, we checked the subclavian flow, it was absolutely fine, and the lima-rima graft was also flowing beautifully. This was a carotid case. Look at the femorals here, impossible to go down this route. So we went from the carotid, that is from the neck artery, and we went down, did the TAVI, and you all can see the flow of the carotid after that. So beautiful flow down the carotid as well. Other features, bicuspid valves, they also do very well with TAVIs. You will see here, the valve doesn't open well. So if you'll see in the middle, the balloon will actually push the valve open, and you expand the valve very well, and therefore you get a great result. This is the last type of variety I will show, which is called valve-in-valve, where in the pre-existing surgical valves, we've put TAVI. So you will see that there is a baseline surgical valve, and in that, we've put a new TAVI valve. So the options are limitless. And while we follow guidelines and see which patients are operable and inoperable, we have all these exclusion criteria in trial. Your patient, if he has COPD, liver disease, renal disease, they immediately become inoperable. When you have associated valvular diseases, now you have options for that as well. For MR, you can do a clip. For MS, you can do BMVs. For tricuspid valves, you can do tric valves. Associated coronary disease, we can do simultaneous angioplasty and simultaneous TAVI together. This week we are doing 4 TAVI cases, of which 2 patients we are going to do an angioplasty, one to the left main and one to LAD, and then do the TAVI. So the TAVI should be thought of as a good lifetime option for the patients, because even if in the life they need another TAVI or they develop aortic stenosis again, they can still have another TAVI in TAVI. So these are just the permutation and combinations. So we need to talk to our patient about the next 10, 20, 30 years and how their options for TAVI as a lifetime option change.
Please conclude.
So, to conclude, I would like to say that TAVI has excellent and reproducible outcomes. Anatomical features should be suitable and your vascular access should be feasible. The lifetime management of TAVI should be discussed with the patient, not just you'll have a good outcome today. And our multidisciplinary team is the crux to the management of these patients. So once again, the take-home message is that all patients are candidates for TAVIs. You saw the variety of patients we showed, all done at Jaslok in our team, with our team. The only high-risk patients should be considered for surgery. So now this is how our thinking should change. Thank you so much.
Thank you, Dr. Nihar, for a wonderful talk. May I request a very prominent pediatrician, my favorite doctor, Dr. Pankaj Parekh, to please give a token of appreciation for our first speaker for the morning. And simultaneously, I request Dr. Bharat Shivdasani to load his presentation. Thank you, Dr. Nihar.
Just a word about TAVI program. We were the first one to perform a transcatheter aortic valve replacement way back almost 6 to 8 years ago, and that was a mayor of Bombay, Dattaji Nalaude. And the complexity that we have handled has given us tremendous amount of encouragement. And out of 90 plus cases that we have done, there have been practically zero mortality. That I think is the thing. So I think in a suitable cases, this has emerged out as a very good option for the suffering human beings suffering from aortic stenosis. Thank you.
Dr. Bharat Shivdasani, our second speaker, is on the dais. Welcome.
Good morning, friends and colleagues. So today's topic for me is management of chronic heart failure. But I have to confess that I was suffering from management of chronic hunger syndrome, which the organizers of this lovely Educon have taken care of with delicious papda and that chutney which goes with it. So now I'm well equipped to talk on this subject. So from complex tower, we are coming to a simple area, and this is one in which all of you are specialists. This is your field, and this is what you have to manage in day-to-day practice. So a simple definition of heart failure: it's a complex clinical syndrome with symptoms and signs from a structural or functional impairment.
Hello.
So there are two aspects: the ventricular relaxation and filling, which is the diastole, and the contraction. Just give pointer, eh? Or the systolic part, which is the ejection. So this is obviously an increasing problem faced by you in clinical practice, because the incidence of coronary artery disease, diabetes, CKD is only increasing. So more and more patients are landing up with heart failure. The percentage will increase by 10% in the next decade. And this leads to a lot of loss of quality of life and functional impairment. So there are 4 basic stages: A, B, C, and D. In stage A, remember, it is only the risk factors. Patient is not symptomatic. So you have hypertension, diabetes. Please don't forget obstructive sleep apnea as one of the contributing factors. In stage B, you have some structural problems which have set in. What do you mean by that? Patient has LVH on ECG or echo. You have some valvular regurgitation or stenosis, as you heard. Okay? But at this stage, patient is still not symptomatic. In the common, when the patient comes to you, in B and C, patient is symptomatic with signs and symptoms and has heart failure. Either it is the first episode, then patient improves, then decompensates, okay? And this is stage C. In stage D, they are advanced, requiring lot of therapy, get repeatedly hospitalized, and require advanced therapy. Pointer hai kya? Okay, okay. For you friends, important, this arrow is all over the place. For you, basically, for those of you who come into hospital at the time of pre-discharge or from the time of discharge, you will be treating the patient. So whatever optimal therapy you need, that is the time to initiate it. Now, how is heart failure categorized today? Reduced EF is when your EF is 40 and less. Mildly impaired, EF 40 to 50. And preserved EF, your EF is 50 and above. But you still can have heart failure. And how do you then recognize this? Use your NT-proBNP and BNP levels, which are elevated, or use the information that we send you on the echo. Look at, now make it a habit, look at your E by E prime, or if somebody gives you the global longitudinal strain. So E by E prime, say more than 12 and above, you think that this person may have early, at least diastolic heart failure. The GLS less than minus 15, keep your eye out. This patient is on the verge of heart failure, if not overtly manifest. Now this heart failure preserved EF, कुछ इधर आप लोग का problem है इसका. So it's like a big elephant in the room. It's there, but you don't recognize it. Okay, this is heart failure, preserved EF, and it arises basically out of impaired ventricular relaxation. The myocardium is stiff, and you have endothelial dysfunction, and there may be some pulmonary hypertension. Heart failure, mildly impaired or preserved EF, more common in elderly, more in the females, okay, obese patients with a BMI more than 30, CKD, GFR less than 50 or more towards 30, patients with atrial fibrillation, COPD, obstructive sleep apnea, here heart failure, preserved EF. So keep in mind that. Now, when you are assessing a patient for heart failure, naturally, don't take shortcuts on the history because that will give you the best clue. Your clinical examination, your edema, spare some time, look at the JVP, auscultate and look for crepitations. And you can add on now your BNP levels, plus your investigations, X-ray, 2D echo, which will help you to categorize which category the patient falls in, and then how rigorous and intensive and what is your choice of treatment. Now, there is a score which has been designed, but I will not get into that. It's basically a simple score, heart failure, preserved EF, H2FPF. So if you have an obese patient, if you have a hypertensive who is requiring 2 or more drugs, patient has pulmonary hypertension, is elderly, and has elevated filling pressures. Now, if your score is 2 or less, your likelihood is low. If it is 6 and above, yes, this patient has heart failure, preserved EF. Okay, so this is a clinical score which you can use. You can just have a chart in your clinic. Simple causes, you must remember your IHD, valvular heart disease, whether regurgitant or stenotic. And today, a lot of patients are on chemo. So don't ignore that, because now that is becoming a small little specialty on its own, and they require a lot of treatment. Then other various causes which you can come across, I won't go into that. But today, importantly, COVID-related heart failure has become an important subject. And so don't forget that. Keep that in mind. Whether it is post-viral or post-COVID, that is an issue. The good thing is it may be transient and the LV function can recover. So don't be disheartened, but these patients do need a close follow-up. So apart from your routine blood tests, don't forget looking for anemia, because correction of anemia is very important for heart failure. And obviously, if you suspect the patient has COVID, naturally all of you have treated, so you would have looked for that. So don't forget that. The biomarkers are now have a big role, either to rule out heart failure or to rule in, and to see how your treatment is progressing. Is your patient doing well in terms of symptoms and in terms of the value? And then naturally, on the basis of the value, the prognosis of your patient will vary accordingly. Also remember, this NT-proBNP levels can be affected by certain non-cardiac situations. So the level and value in elderly, especially if you're more than 75, the value goes up above 1,000 or 1,500 for the NT-proBNP. So be a little sensible and practical. Don't dive in and try and over-treat or be over-aggressive, because what may land up is that, you know, the kidney function may be impaired by various drugs.
2 minutes.
Okay, so apart from the routine X-ray, 2D echo, where required, you can use the cardiac MRI to rule out myocarditis and cardiomyopathy patterns. For your treatment, the main areas are beta blocker, ACE, ARB, or ARNI, okay, which act on the various different physiologic pathways. Don't forget, in this whole cascade of treatment, don't ignore if your patient has heart failure, atrial fibrillation, then you must anticoagulate, correct the anemia, okay? And don't forget your vaccinations, whether it is COVID, your influenza, or your pneumococcal. So these are the treatment options that you have: ARNI, beta blocker, MRA, and SGLT2 inhibitor. To this, you add ivabradine if the patient is in sinus rhythm and the heart rate is, say, 80, 90. You try and get it close to between 60 and 70. If your patient is in atrial fibrillation with a fast rate, don't ignore our old friend digoxin. If the creatinine is high and you can't use ARNI and certain other drugs, then isolazine, which is hydralazine plus nitrate combination, provided the blood pressure is good, is another option that you have. Vericiguat is a new molecule. It is a cyclic GMP inhibitor. In addition to all these, if your patient still has heart failure, is symptomatic, or if the creatinine is high and you cannot use SGLT2 or ARNI, then vericiguat, or the tablet called Veruco, is one which can be used. So all these molecules, which all of you are familiar with, ARNI, ACE, ARB, beta blocker, your spironolactone or eplerenone, and SGLT2, EMPA or DAPA, all enjoy class 1A indication and benefit in heart failure. If your patient has heart failure and some ventricular arrhythmia, either on the ECG or the Holter, you pick up, say, non-sustained or multiform ventricular premature complex with a low EF, 35 and below. Don't forget ICD as an option, because it adds 20% incremental value in mortality reduction. Similarly, on ECG, if you have LBBB pattern, broad QRS, patient is in heart failure, is symptomatic despite all your treatment, don't forget to put biventricular pacemaker. So these are interventions. They are expensive, but there is definitely a place for them in therapy.
Please conclude.
Okay. For those who are not, medicine is not enough, advanced heart failure, you have ventricular assist device or cardiac transplantation. Now, in the sequence of introducing this therapy, your SGLT2 and beta blocker first if the BP is borderline. If the BP is good, 120 and above, ARNI comes in first. All of them should be introduced as soon as possible within the first month to improve your benefit outcomes. So finally, to tell you, my friends, In short, catch and save a failing heart with the best treatment options that you have so that your heart can continue dil dhadakne do. Thank you.
Thank you. Thank you, sir, for a wonderful lecture.
Coming to see what is coming at home. I spent my childhood, I spent my early education, it happened in Sea Ward, and each one of you, to me, in one way or other connected, because I have been brought up on Sea Ward in Garware area. So it's coming home, friends. Well, in order to satisfy your needs, what you require from me, it's not important what I know. What you should know, which makes you efficient to make a diagnosis of a most treacherous disease, which sometimes can harm your reputation. Time and again it has happened where a chest pain has been wrongly diagnosed as acidity, gas, gallbladder, and time and again it has happened at a benign GERD has been diagnosed as coronary disease and could create a neurosis in the mind of the patient. Let us imagine that I'm in your position and middle of the night I get a phone call. The doctor said, my husband is having severe chest pain. Please come. Just a small question before I further go. How many people have possession of ECG machine? Please raise your hands. I think I would say the time has come where a family physician should have an ECG. And should there be a need to train you to make a simple diagnosis in ECG, I, on behalf of Just Look Hospital, will take regular training classes for you. Well, so then I'm coming to the story first of all. Let me have the second slide, please. Acute coronary syndrome, which is the commonest cause of mortality after the age of 40, and of course below the age of 40 the commonest cause is accidents. So even there also is an important cause of death. We have four things: unstable angina, non-QA myocardial infarction, by that I mean ST depression myocardial infarction, an ECG term, transmural QA myocardial infarction, that's ST elevation myocardial infarction, again an ECG term, and sudden cardiac death, which itself is a topic we can discuss separately. And these are all fluid. An unstable angina can slip into an ST elevation myocardial infarction in a matter of few hours. An ST depression myocardial infarction can go into ST elevation myocardial infarction also in a matter of hours. All are serious, and they slip one into other in no time. Let me talk about, you have a patient who complains to me that when I walk, Dr. Mehta, I get pain in the chest, radiating to my left arm. When I stop, it goes away. It's easy. A medical student will be able to diagnose that this is a chronic stable angina. And suppose today somebody guarantees me a chronic stable angina will remain chronic stable angina, then I will treat it as an arthritis. Take a pill and continue to live life. No. It reduces the lifespan because sooner or later it will terminate into an acute myocardial infarction and kill him. Now, therefore, it is important. When is we call unstable angina? A man who has a chronic stable angina, that I walk, I get pain, I stop, again I walk, I get a pain, has a stable demand-supply ratio. When the demand is increased, the supply becomes inefficient, pain occurs, and it goes away fine. So far so fine, people can continue life with medication, and there have been debates about going on whether they should need angioplasty or bypass surgery or not. We'll not discuss that. But important thing for you, that when it becomes unstable, the matter is serious. And how do I know it is unstable? One, a regular angina patient says, my effort tolerance is decreased, I can't now walk up to bathroom. That's a serious matter. Or I'm getting incomplete relief. Formerly sorbitol was giving me relief, but now I'm not getting complete relief. I have to take 2, 3, 4 tablets. It's an unstable angina. Pain lasts longer. It used to go away in 5 minutes. Now it doesn't go away in 20 minutes. It's an unstable angina. Pain comes very easily. I take a million walk, I have to stop. It's an unstable angina. The unstable angina means that something has progressed, and whether it will progress further to culminate into a total occlusion of an artery and result into myocardial infarction or not is uncertain. But we have to be prepared. We have to be prepared just in case. So therefore, given circumstances, for example, suppose somebody is working as a very senior officer in Tata Consultancy Services, who has never had any pain in his life and nothing. And in the middle of the night, he gets discomfort in the chest. He's about 45, he has a stress, he has a diabetes, he is a smoker. आँख बंद करके आप समझ लो कि unless proved otherwise, this has to be taken as cardiac. Let it be crying wolf. Let it be false alarm. But even if you send him to the hospital, or if you go home and take an ECG, maybe normal, but sometimes you will pick up the change. Whenever there are pain ongoing and you take an ECG, 90% of the time you will be able to detect changes. And that patient has to go to the hospital. Take it, what do we do? But before I go send him to the hospital, just give him a tablet of aspirin, no heparin, no sorbitrate, no nothing, just a tablet of aspirin, pack him off to the nearest possible ICU. That's the treatment of unstable angina. Now, why unstable angina occurs? Let's see the next slide. This is a plaque in the coronary artery. That plaque, practically after the age of 45, we all will have. All of us will have. But those plaques are mild. And when this plaque ruptures under a situation of stress, imagine how many celebrities died below the age of 40 or 50 in last recent time. Siddharth Shukla, 40. Raju Srivastav, 53. KK, 53. They never were ill. They were VIPs. They could have got best of the treatment, but they died. They died because of incomplete diagnosis. Missed by them. Missed by them, I'm not responsible. But missed by us, surely I'm responsible. Okay, now, when this plaque ruptures, immediately at the site of the rupture, platelets run. People who come back, there was Dr. Prasanna Nyadis, who came from his KEM assistant cardiologist or professor of cardiology, did a gym, went home and died. So therefore, when this plaque ruptures under a situation of stress, excessive exercises, or mental stress, or physical stress, whatever it may, plaque ruptures. Plaque ruptures, the platelets immediately run there. When these platelets run, and when the platelet disintegrate, they produce substances like serotonin and vasoactive substances. Spasm takes place, and suddenly the patient experiences unprovoked chest pain. He was doing nothing and he got pain. And at this point of time, when the artery is not totally occluded and it will a platelet-rich plug, at that point of time, patient will get pain. And he still has not infarcted. For infarction, the flow should be completely stopped. Within a matter of few hours, this is a white clot, platelet-rich clot. Within a matter of few hours, there will be a red clot. Thrombus-containing fibrin-rich clot. This fibrin-rich clot will produce acute myocardial infarction with ST elevation. Now, treatment is different. That's why we are differentiating. Here the treatment is aspirin, beta blockers, maybe clopidogrel, heparin, but not a thrombolytic agent. Thrombolytic is a misnomer. We should call it fibrinolytic. There's nothing like thrombolytic, fibrinolytic. Here, he requires a fibrinolytic agent. We'll discuss, if time permits, whether it can be given at home or not by you or not. That I'll discuss in a minute. But when this occurs, the next slide, please. The whole artery gets completely closed, no blood supply reaching to the suffering area, the target area, and the patient gets acute myocardial infarction, and this is the commonest cause of sudden cardiac death. 50% of the patients do not reach the hospital. Only lucky ones reach the hospital, and that too, if they reach within 1 hour, they will go with tremendous benefit. That's where the expediency of an acute myocardial infarction diagnosis and cut down. I'll show you in the last slide how to cut down the time. And when partially occluded thrombus on the left-hand side, it will produce ST depression myocardial infarction. And why is it important? Because, the next slide please, that we know that when there is ST elevation myocardial infarction, all of them will be requiring thrombolysis except 19%. But on the other hand, when the thrombus composition, ST elevation myocardial, they all have a fibrin-rich clot.
2 minutes.
Small 29s, don't worry, they're learning. 29% will require still a fibrinolytic, but we can't help it. We are unlucky because we have no way to know whether there is an infarct is rich in fibrin or is rich in thrombin. I don't know. We can't. Or whether it's a platelet. I don't know, because SCG, ECG can't tell you that. And therefore, the angiography is very important. We'll discuss it. The next slide, please. If there is no myocardial infarction, in about 6 months' time, mortality is only 5.5%. But if the infarction develops, the mortality reaches to 18.3%. Therefore, it's important to diagnose this. Now, we'll go to jump the slides because the time is short. I think it's a long talk, but I wish I had more time. Okay, this is what should you do when at home? I think you should have a very high suspicion index. If the patient's circumstances suggest that there are many risk factors by Framingham study, multiple risk factors, so it's a high risk case, intermediate risk, a low risk case. Then in that situation, you will probably consider him seriously to send to the. It may happen once in a while that the family may blame you, misunderstand you, that you frightened us. Not to worry. You're not frightened them. You've taken an appropriate judgment. It is much more dangerous to lose a patient with underdiagnosis rather than to have a little bit of criticism with overdiagnosis. And the last slide, please. Last slide. Keep going, 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 keep going. An acute myocardial infarction, I'll talk at some of them. Just bring it back, bring it back, bring it back, bring it back, bring it back. If you treat the patient within 1 hour, the mortality is hardly 3%, less than dengue, less than malaria and whatnot, within 1 hour. There are so many factors involved to diagnose within 1 hour, so many factors, which we can discuss at a separate time. Once the 1 hour is over, there is a steep drop in the survival rate. And thereafter, within 4 hours' time, it's a plateau. So then there is no that much expediency. But if you bring the patient door to balloon to the door of the hospital, and if I have to take him into the cath lab, I have to develop super fast pathways within the hospital so as to take the patient most expeditiously to supply him with 1 drop of blood as fast as possible by balloon. Then my job is done. And finally, the last slide now. In enhancing the early treatment, patient education, they should not apply, take an Eno fruit salt or apply balm or something like that. They should immediately call a doctor. The phone number should be ready with the patient. 2, transport. In Bombay, transport is a huge problem. Go to the nearest possible intensive care unit with a cath lab facility. That's the most important thing. 3, in-hospital diagnosis should take only 10 minutes. Immediately connect the patient to the ECG. If there is an ST elevation, he moves up into the cath lab. And the lift is, moment you give me a call from outside that, sir, I'm sending a patient with a chest pain, I keep my lift ready, I keep ECG machine ready, I keep echo machine ready in the cath lab, in the casualty, and the patient moves into the cath lab, so on and so forth. And in hospital, super fast pathways, and finally, if for some reason or other, if there is likelihood of delay, such a patient should be given thrombolytic therapy. Thank you very much.
Thank you, Dr. Ashwin Mehta. May I request Dr. Kulin Kothari to give a token of appreciation to Padma Shri Dr. Ashwin Mehta.
Sir, you have been a master storyteller. Fantastic, a very good educative, and sorry for our disturbance.
I wish to welcome two senior doctors who are amongst us, Dr. Jhankaria, Dr. Anita Borges, we welcome you. Dr. Kulin Kothari, senior ophthalmologist. Thank you, friends, for being a part of this Sunday morning academic feast. I'm glad he didn't take heart as his specialty, because many people would skip a beat, you know. When I was in college, I remember many people skipping a beat when he would walk into the college. So MAZDA TUREL presenting on brain and spine.
Thank you. I'm not used to so much of flattery, but rightly said, we'll move over to a slightly more important organ. Sir's not listening. So we'll just briefly talk about the commonest symptoms that affect the brain and spine, and what as a general physician one can do to help these patients. As a corollary to chest pain, if any patient complains of sudden facial deviation, if there's a weakness in an arm or a leg, if there's a speech disturbance, not only that, now they've moved it to if there's any sudden onset double vision or sudden onset imbalance, you have to consider it as some form of a stroke and ask the patient to immediately go to a hospital that can diagnose it and that can treat it. And it's important that you don't advise a patient over a phone to please take aspirin, which you can do for the heart and which you must do for the heart. If sometimes a stroke is hemorrhagic and you advise them to take a blood thinner, they're going to have further bleeding into the brain. So even if there are symptoms that could suggest that it's an ischemic stroke, I've had several patients who've had sudden onset facial deviation and have been given aspirin when it's actually a subdural hematoma that increases in size, and that makes the job of the neurosurgeon very difficult. So the best thing you can do is ask a patient to go straight to the emergency of the closest hospital, because time is of essence. So that in a nutshell just covers everything you need to know about stroke. Because then what happens to the patient once he reaches the casualty of a hospital is the other person's job. Similarly, headaches. 90% of headaches can be managed by anybody. But it's these 10% of headaches that are sinister which need to be appropriately looked at. If a patient says they've had sudden onset severe headache, even if they've had that yesterday and they're absolutely okay today, you should still insist on getting a CT scan, because a sudden onset severe headache is a subarachnoid hemorrhage unless proved otherwise, and this is what it looks like. And if treated appropriately, quickly, either endovascular or open surgery, the patient's chance of rebleeding is very, very minuscule. So those are acute headaches. Subacute headaches is another ball game altogether. This is just a pictorial representation of headaches. The last one is my favorite. But subacute headaches, if a patient has headaches for about 2 weeks, you ensure that you've ruled out a refractory problem, sinus disease, ear infection, obstructive sleep apnea. But anybody, and some neurologists disagree with me, anybody who has a headache that is more than 2 weeks on, please get an MRI. I mean, an MRI can sometimes be life-saving because you can diagnose brain tumors. I've had in the last 5 years at least 25 patients who've just had a simple dull aching headache that doesn't go. Please note that all brain tumors don't need to present with raised intracranial pressure. You don't have to have headache, you don't have to have vomiting, double vision, or neurological deficit to have a brain tumor. This patient right here, all he had was just right-sided occipital headaches for about 2 to 3 weeks. That's it. No other symptoms, completely okay, no raised ICP. But in the clinic, you can do one test called the pronator drift to see if there's any subtle neurological deficit. So you ask a patient to just put both their hands up, palms facing the ceiling like you do, like this guy is doing. And you can see that the weaker hand will gently drift down to the floor. But you have to give this test about 30 seconds to 1 minute. And you can see his weaker hand is dropping to the floor. He has a large glioblastoma abutting the motor cortex, and we use intraoperative neuromonitoring to operate on these patients to make everything look fancy. And these patients can come out of surgery completely unharmed with complete excision of these tumors. So please get an MRI. It costs very cheap. Dr. Jhakaria will give you a discount. But don't neglect getting an MRI done. Now, these patients, you don't really need an MRI to diagnose that they have a brain tumor. He's waited too long. His brain tumor is actually jutting out of his head. Someone attempted an operation by just cutting through the middle. There was excessive blood loss. They could not continue the operation. They closed and sent him to us. And then this is what it looked like when we removed the entire bone and then refashioned the cranium with a cranioplasty. Neurosurgery has now become very, very safe because we have the advent of functional MRI. We know what the hand area is. We know what the leg area is. We can choose an appropriate trajectory to reach tumors. We don't remove tumors like this, like they used to 10, 15 years ago. We've got very, very advanced modalities of treatment. We can even operate on patients awake, especially tumors that are in eloquent areas, such as the motor cortex. You don't want to cause any harm. You can actually operate on these patients awake while checking hand and leg function. A resident checks the function while you're operating on this patient, and then if there's any deterioration of function, you can safely stop the excision rather than doing a complete excision and causing a neurological deficit. So these are tools in which you can perform a safe maximal resection while a patient is actually watching his own surgery on a screen in front of him. The other things that can cause headaches and that are often missed are pituitary tumors. Patients just present with headache and subtle visual dysfunction. And again, in the last 5 years, I've had patients who've had cataracts removed for pituitary tumors. So it's very important that an MRI is asked for if you suspect if the patient has a bitemporal hemianopia, or especially if a patient has features of excess hormonal secretion, like gigantism, Cushing's, infertility. I have had a few patients who've been treated for infertility for very, very long, but they haven't had an MRI of the brain done, and it shows a large pituitary adenoma, and we remove it and they conceive the next day. Not the next day, but this is endonasal surgery has also become relatively safe, relatively straightforward. We can remove these tumors from the nose, preserving optic nerve function, preserving pituitary function, and these patients can go home in 2 to 3 days after a safe, complete resection of these tumors. It's now pretty simple, but just because I'm saying it's simple, don't try it on your own. Another very common symptom you will notice in the clinic is memory impairment or abnormal behavior. Or someone says, this old uncle of mine has started behaving abnormally, he's hitting everybody, he's passing urine in the house. And without doing a scan, sometimes they're started on antipsychotics, sometimes they're given dementia medication, but sometimes frontal lobe tumors can present with these very symptoms that we attribute our grandparents to have. So it's very important that a scan is done.
2 minutes.
But at the same time, it's extremely essential that you rule out all reversible causes of dementia before you can label a patient as having psychiatric problems. And another common misdiagnosis often made is that of trigeminal neuralgia, where patients have a lot of tooth pain. Patients almost always go to a dentist, get a root canal done, get 3 root canals done, get 5 root canals done. I've had a patient who's been advised a jaw replacement, but the diagnosis is actually that of an artery pinching on the nerve, they have typical very sharp shooting pain, and it's a very, very simple operation that just requires you to put a piece of Teflon between the artery and the nerve. There are other modalities of treatment for trigeminal neuralgia, but as a surgeon, I don't like to talk about them. And in the last 2 minutes, we'll briefly talk about spine problems that are very, very commonly affecting people. And the best thing you can do to avoid surgery for anybody is to maintain appropriate posture. The way you sit with your buttock pushed right back into the chair, and the way you sit in front of a laptop, or tie your shoelace, or lift something from the ground, or even get out of bed, which seems like a straightforward mechanical problem, should be done very, very carefully. But I'm just going to go through a few cases. It's very important that you diagnose mechanical back pain. It's some kind of pain that gets worse on loading the back. And it's extremely imperative that patients who have chronic back pain get flexion extension x-rays. We usually only ask for x-ray lumbosacral spine AP lateral, but flexion extension tells us an instability, like you can see in this gentleman here. There's subtle movement, and that's the source of the pain. And if that's not picked up, we can completely miss the diagnosis. You can see this lady was just treated conservatively with no real improvement in her symptoms. We did a minimally invasive operation. You can see how debilitated these patients are. And now with minimally invasive spine surgery, it makes a world of a difference. You know, she can't even walk a few steps. She's bending forward. And after surgery, they really get a new life, completely free of pain. You can see this other patient has a 1-foot scar in her back, has had 5 previous operations, but no one's treated the actual instability. You can see the slip of L4 over L5, and we just fixed that with a minimally invasive operation, and their pain disappears. It's also very important not to misdiagnose SI joint pain for lumbar spine problems, because SI joint pain requires a completely different treatment paradigm. But any patient, again, with back pain, who has any of these symptoms does require an MRI. Any back pain that's not going away for a period of 2 weeks, you should get an MRI. It's not always muscular, it's not always mechanical. A lot of patients who've had malignancies and who have back pain 10 years later, even if they're in remission, should have an MRI, because it is metastasis unless proved otherwise. Now we have a lot of patients on dialysis who get spondylodiscitis. A lot of patients who are immunocompromised who get spondylodiscitis, and all they present with back pain. So you must not say that all back pain is related to posture, related to muscle. Please get an MRI, unless you don't want to get to this stage where there's complete destruction and then a minimally invasive operation won't help. You'll have to put all this metal in a patient.
Conclude.
Yes, just one last case. So the advantage of minimally invasive surgery is all of the above, but you have to remember that spinal tumors, they present with back pain on lying down. They don't present with back pain on walking. So that's the other differential diagnosis to make. Similarly, when you get cervical pain, again, all of it cannot be muscular or postural, while 90% of it is. If you have cervical tenderness, if you have restriction of neck movement or pain radiating to the arms, my timer is still showing 12 minutes. Okay. So it's very important that before we select any patient for surgery, you have to have the correct patient. You have to operate for the correct indication, on the correct side, at the correct level, and the surgeon also does matter. See, for example, this gentleman was, because of the way he walks, was diagnosed with having Parkinson's disease. And yes, you can have some features of Parkinson's in the elderly, the way they walk, their gait is. And he was treated with anti-Parkinson's medicine, continued to worsen on anti-Parkinson's medicine, no significant clinical improvement. And but no imaging of the spine was done, only an imaging of the brain was done. And we imaged the spine and examined him, and he had a very, very classical myelopathy rather than rigidity, what is seen in Parkinson's. He had spasticity with exaggerated reflexes, and you could see the compression. This is the day before he was admitted into the hospital. And then we operated on him, did a simple laminectomy at the thoracic spine. You can see the thickened ligamentum was really pinching on his spinal cord. And this is the way he was walking 3 months after surgery. So the correct diagnosis in these patients really makes a difference. And that is why, to enlighten the general physician, I make it a point to try and write these articles in the newspaper every fortnight in the Sunday midday, if you get a chance to read them. Just to be able to educate what we do on a daily basis. All these patients require calcium and vitamin D supplements, and that can also be a common cause of chronic pain. All our progress is not progress related to surgery alone, it's all these specialties, and that is why the success of modern neurosurgery is very, very high. I just want the last 30 seconds to end with a case where this patient, you can see a young 30-year-old guy with a large intramedullary tumor, only back pain, nothing else. General physician astutely diagnosed it, sent it to us. And these intramedullary tumors are like these rolls, you have to open up the entire spinal cord, and the trick is to be able to only eat the green part of the mithai and preserve everything else. You can see this enhancing thing. We removed the problem with this particular case was that we do all these operations with intraoperative neuromonitoring. And neuromonitoring in this patient did not work. Did not work because the spinal cord was way too compressed, though he did not have clinical signs of myelopathy. So the question is, if neuromonitoring doesn't work, how do you go ahead with a surgery like this when a patient is completely open? We've got a 1-foot incision in his back. We've removed his bone. Should we go ahead with surgery? Should we allow him to become paraplegic and then go ahead and operate on him? A lot of difficult decisions have to be made on the table. However, we went ahead and removed this tumor completely. And unfortunately, this patient was paraplegic after the operation. So it was very, very devastating. I was thinking to myself whether this was the right decision that we made. We should have not operated on this guy. But anyways, if he went anywhere else, the neuromonitoring would not have worked because the spinal cord compression was that significant. And I was cursing myself for a couple of months until 1 month later, he started walking with the help of a walker. And then 3 months later, he sent me a video having climbed 20 floors of his building and running on the terrace. So, neurosurgery is a challenging field. It requires the correct amount of decision making and the right amount of expertise. But we're always learning, and that is why we always have stories to tell. I thank you very much for having us over here and being able to share what we do.
Thank you, Dr. Mazda, for a wonderful talk. May I request Dr. Jawahar Mukhtiar to present a token of appreciation for our very dynamic and handsome Dr. Mazda. I wish to welcome Dr. Snehal Sanghvi, who is with us. Good morning, sir. We thank you for coming over. Please load his presentation. Our next speaker is Dr. Mohit Kukreja. He will be talking on evaluation of shoulder pain, diagnosis and management.
This is Dr. Mohit Kukreja. I'm a full-time consultant at Educon Hospitals, Mumbai Central, and I would like to take this opportunity to first of all thank the C Ward Medical Association and the Bombay Medical Union for organizing this and helping me be a part of this, and of course Educon Hospital for helping us get connected. So my talk is basically going to be focusing on evaluation of shoulder pain and its management. We're going to talk a little bit about my background quickly, and then the specialized cases that I do in practice, and then get to the topic right away. So I'm an alumni of Grand Medical College and JJ Group of Hospitals. I'm extensively trained abroad, doing American Board Certified Fellowship training in the US. Mainly trained at Boston University and Brown University, doing American accredited fellowship hands-on training. And then I came back here, joined WOCAR, and currently practicing as mainly an arthroscopy surgeon, doing sports orthopedics and minimally invasive surgery. My specialty is joint preservation, so I believe saving what God has given us and helping us diagnose the problems in time and saving the patient from a knee replacement early in his life. I also specialize in shoulder, elbow, and wrist surgery. So this is what arthroscopic surgery is. It's basically putting in a pencil-sized instrument in the joint and taking care of the problem from minimally invasive keyhole techniques, which has a lot of advantages, which I'll discuss later. So sports injury is basically injury that can happen, a gamut of injuries that can happen anytime we are active in any kind of sports. But of course, it's not restricted to just playing sports. I see a lot of patients who meet up on in a motor vehicle accident or had a fall just while walking on the street and had the same ligament injury that can happen in any sports. But I think diagnosing these problems in time and treating them is extremely important for them to not end up getting arthritis in the future. So this is how we do arthroscopic surgery. So it's kind of playing a video game, and I think I'm really privileged having a remote control in my hand and doing surgeries every day. It's fun, and basically looking at the television in front of us and taking care of the problem without opening the wound. So no blood loss, faster recovery, faster healing, and faster return to normal life. So coming back to the topic, so what is compromised shoulder function? Compromised shoulder movement or function can happen as a result of pain, stiffness, or weakness in the shoulder joint, which can lead to substantial disability because we're just not able to use our arms and do our daily regular activity. So it's the third most common cause of musculoskeletal pain and consultation in the primary care setup. And most commonly, it's affecting people that probably use their shoulder a lot. So right from occupations who are like construction workers, wrestlers, or hairdressers who actually strain their shoulder at work, or also physical activities like lifting heavy loads and repetitive awkward movements on the shoulder joint. Psychosocial factors also are contributory. So these images actually show the anatomy of the shoulder joint, which is again a mixture of the capsule, which can be affected like in a frozen shoulder, the ligaments which can be torn up and can lead to a shoulder dislocation. Of course, the rotator cuff tendons which are encasing around the shoulder joint. There are 4 of those, and any tear in the tendon can lead to excruciating shoulder pain. And of course, the bursa on the top in between the acromioclavicular joint and the glenohumeral joint that can lead to bursitis. So this is the front aspect of the shoulder showing the rotator cuff tendons. You can see the tendon in the front is called as subscapularis. The one in the top is the supraspinatus. And then the view of the back, you can see the 2 tendons at the back which also form the rotator cuff are the infraspinatus and the teres minor. Above these tendons we have the encasing major muscles, mainly the deltoid muscle in the front side and the back of the shoulder, which mainly gives the contour of the shoulder joint, and then major muscles in the front, which are the pectoralis major, and muscles at the back, which are the teres major and the latissimus dorsi. So history taking, I think, is extremely important for all of us when we see a shoulder joint patient. It's extremely important to actually decipher if it's an intrinsic cause of shoulder pain or if it's an extrinsic, which I'll detail in a few slides from now. But onset, duration, and progress of pain, the type of pain, is the pain on rest or on movement? So if the pain is at rest, it could actually indicate a graver problem like infection or a tumor. And if the pain is mechanical, then it probably indicate some sort of tendon affection or a musculoskeletal problem. Also, pain at night is something that should be elicited. So night pain is very significant in problems like rotator cuff tear. So even while the shoulder is by the side, the patient will have a lot of pain, and also sleeping on that shoulder is going to be difficult for the patient because of the pain. Along with that, of course, we should ask about the neighboring areas around the shoulder joint as to just to rule out if there is any referred pain coming from another organ to the shoulder joint. So any neck, thoracic, or upper limb pain that the patient might be having, any history of trauma or fall or a twist or lifting something very heavy could actually indicate a tear in the shoulder, especially in middle-aged and old patients. Also, there's any history of recurrent dislocation of the shoulder in the past. Occupation and any sporting activity is extremely important and should be asked, because that would indicate that they're straining the shoulders all the more. And also if any other joints are affected, but actually it could be like a multiple joint problem or a systemic problem rather than just restricted to the shoulder. Systemic symptoms should be elicited such as fever, loss of weight, loss of appetite, to rule out any infection, also to rule out any tumor that could be somewhere else, and we could be facing with a Mets in the shoulder. I've seen patients where we actually diagnosed the primary after actually diagnosing the cause of shoulder pain, which was a Mets that was missed for a long time, for a year or so, without being diagnosed or investigated, just labeling it as a frozen shoulder. Also, significant comorbidity or other conditions, medical conditions, should be definitely asked about, and also about the drug history. So examination of the shoulder joint is extremely important. I think disrobing the patient and exposing the shoulder as a whole, also being able to see the scapular area, is extremely important for us to know about the pathology, how chronic it is. Examination of the neck and seeing the range of motion to rule out any referred pain from the neck is important, and also inspecting the shoulder joint to see. So you can see the image down on the left side where there is scapular winging, which could be a cause of shoulder pain just because the glenohumeral joint is not moving normally, and we can easily see it by exposing the scapular area. You can see this, the amount of shoulder swelling that we can see, which would probably be missed if we are examining the patient with the clothes on. And of course, atrophy of the supraspinatus and the infraspinatus, which is easily visible on an examination from the back. Palpation of the various joints around the shoulder is extremely important. So AC joint, which is the acromioclavicular joint, which is the joint on the top of the shoulder, is sometimes a cause of pain and can lead to arthritis in that joint. So palpating that joint and eliciting tenderness is extremely important. Also checking for temperature and crepitus is important while doing the examination. Checking for strength, especially in a rotator cuff tear patient, will help us diagnose a tear on examination, or at least give us a doubt where we can do an MRI right away. And checking for range of motion. So active and passive range of motion checking is extremely important. So like in a condition of frozen shoulder, there will be restriction of both active and passive range of motion, and most of the times it's a clinical diagnosis. If there is just affection of the active motion and the passive motion is full, it would probably indicate a tear, especially if a patient had a recent trauma. Looking for the painful arc sign for bursitis can help. And then looking for passive external rotation and external rotation lag sign. Like you can see in this patient.
2 minutes.
Sorry. This video is not working, sorry. All right. So the drop arm test is also important, which will help us know about a large rotator cuff tear. So causes of shoulder pain can be many, and we should look out for both intrinsic and extrinsic causes. So the intrinsic causes of shoulder pain can be rotator cuff disorder, like a rotator cuff tendinopathy or tear or a subacromial bursitis. Glenohumeral disorders can be a capsulitis, which is called as frozen shoulder, or rotator cuff tears, acromioclavicular disease, or traumatic shoulder dislocation. Also extrinsic causes could be referred pain from the neck area, could be chest pain, which we have talked about in the morning, referred diaphragmatic pain from the abdomen. Also it could be some malignancy. So this is just an algorithm showing ways to diagnose shoulder pain. So of course, knowing red flag signs are extremely important for us to not skip a patient who has one of these, which would probably require an intervention immediately. So it could be a tumor, and so we should definitely elicit any symptoms of loss of weight, loss of appetite, history of cancer. It could be infection, So asking for fever, checking redness of skin is important. Any history of trauma could indicate a rotator cuff tear or a shoulder dislocation or a fracture. And of course, neurologically, we should examine the distal arm and the hand for any weakness or sensory or motor deficit. So X-rays are extremely important, give an idea about a shoulder dislocation, arthritis, a fracture, as you can see in the left image. Also, a neck X-ray will rule out any neck pathology. And doing an MRI is also extremely important and is 100% diagnostic. Will diagnose a rotator cuff tear, will also diagnose any shoulder dislocation, any cartilage problem. Also to help us know if there is any atrophy in the rotator cuff muscles, which would probably prognostically help us know if actually doing a repair is possible or not, especially in chronic rotator cuff tears.
Please conclude.
Yeah. So quickly, treatment of shoulder pain is a functional holistic approach. Physiotherapy is the first option, and stretching and strengthening both should be attempted. Conservative options are important, and the patient should be allowed for the pain to get decrease with physiotherapy. Cortisone injection and a PRP injection is an option to decrease the pain with injections. Of course, if the pain doesn't resolve, we can do a surgery which would be arthroscopic. So if a bursitis, we would probably do an acromioplasty with just shaving off the acromion underneath. This is how we do a biceps tenodesis for biceps tendinitis. This was how we previously did the rotator cuff tears, and now we can actually do it all arthroscopically. So I do all my rotator cuff repairs arthroscopically, no matter how complex they are, with advantages of minimal scarring, minimal hospital stay, minimal pain and swelling, minimal stiffness. I do a double row repair, which is extremely important and should be done because there are very high chances of a stable shoulder and a long-term good functional outcome with a double row as compared to a single row. This is shoulder replacement, which is an anatomic shoulder replacement for shoulder arthritis. And this is a reverse shoulder replacement, which is another type of replacement which you do for chronic rotator cuff tears or complex fractures. This is how we release the shoulder for a frozen shoulder. You can see how red it looks on as the inflammation is immense. And after we release it, we have full range of motion. So just to conclude and give you some takeaway points, I think it's very important to clinically differentiate between intrinsic and extrinsic causes of shoulder pain. Frozen shoulder is by far a clinical diagnosis, and we don't need an investigation for it. First time shoulder dislocation should definitely be referred to a specialist to know if they are candidates for a surgery right away, or we can conserve it. Rotator cuff tears should be fixed in time, and we should not delay it further because the functional outcomes are best when fixed early. X-rays should always be done to rule out problems like shoulder arthritis and cuff tear arthropathy. And of course, trying 4 to 6 weeks of physical therapy is extremely important initially if there is chronic shoulder pain. And if the symptoms still persist, I think a reference to with an MRI to a sports or a shoulder guy is extremely important. Thank you so much for your time.
Thank you, Dr. Mohit. Can I request Dr. ARUN Shah to give a token of appreciation for our speaker while Dr. Bhavin load his presentation? Dr. Mohit, that was a wonderful talk, but I have my doubt whether a single row, double row or a multiple row will work. If a doctor is as handsome as you, the patient will definitely continue to come to you for a pain.
Can I have a mic?
So moving to the next speaker, Dr. Bhavin Jhakaria. सिर्फ नाम ही काफ़ी है. Presenting on non-malignant indications of PET scan and CT scan.
Yeah, thanks. So I'm also supposed to have what, 12 minutes or 15 minutes? How much was it, Mazda? But I loved what Ashwin Bhai did, you know. It's okay, it's fine. I am going to say what I want to say. I was looking at the program and I realized, and this is a story of my life, right? I'm sandwiched. There's Jaslok Hospital, there's Wokhard Hospital, and then after me is Reliance HN Hospital. And I'm like this sole guy sandwiched among all these big institutions here. It's the way we are sandwiched in our lives, no? Between our parents and our children. It's the same issue that we have all the time.
Robin, you don't look very smashed.
We learn how to preserve
He looks smashing.
Thank you so much. Bread and butter. Sujit is there, and thanks Sujit for all your help. And we have a new molecule called FAPI, which is fibrinogen activated protein inhibitor, but basically it binds to areas of inflammation and infection much more than FDG. And we're trying to explore and see whether seeing all these red areas and activity in patients with interstitial lung disease can help us prognosticate better or not. And this is what we used to see during COVID times, right? Patients would come for PET, for their tumor imaging. Suddenly you'd find lung lesions. The first couple of times we saw this in May and June of 20, there was so much hoo-ha in the department, and the question was whether we shut down the PET CT for 2 days, don't take additional patients. None of that matters anymore. But at that time, we didn't know what was going on. And this is how we used to pick up asymptomatic findings on PET CT due to COVID. And that again then becomes one of these non-malignant indications of PET CT. Right, so to summarize in the body, in patients with PUO, PET identifies abnormal lesions that can be biopsied or evaluated further for etiology, and it's used for follow-up of a bunch of inflammatory infective conditions. Most of the times for TB and sarcoid, it's too expensive to keep doing PETs for follow-up, but you do it for vasculitis, retroperitoneal fibrosis, etc. So, you know, radiologists are the only ones who stick to time, right? And so, therefore, and you have to bear me out on that. So, non-oncology indications in the brain as an adjunct to MR, in the heart, again, usually as an adjunct to MR. And then PET comes on its own when we have to look at patients with, you know, fever of unknown origin, etc., as I've shown in all the other images. So thank you so much for listening to me. It's always a pleasure to speak to all of you. So many familiar faces, so many people I'm seeing for the first time after, you know, COVID. Otherwise, earlier there used to be so much more interaction. And all of you have a great day. You have a lovely program. I've seen Anil Bhai, you've put in a lot of effort with the entire team to create an amazing program. So thank you. All the best.
Thank you, Dr. Bhavin. May I request my handsome husband, Dr. Saumil, to give a token of appreciation to Dr. Bhavin. And simultaneously, if Dr. Arun can load his presentation on acute ischemic stroke, a paradigm shift. Time is brain to imaging is brain.
To talk after two dynamic people like MAZDA and Dr. BHAVIN JHAKARIA. So let me see what I can do. And of course, I must tell that my partner in the whole this program, Dr. Nishant, is going to take less time, so I may take a little more time. No, I'll not try to finish in my time. So I'm not timing myself, so I hope you'll be fair. Yeah, so let me, this talk is, the title is a little funny, and I think Dr. Anil Bhai was asking, what do you mean by this title? So I'm just going to clarify that that's the only thing which I'm going to do in 20 minutes at my disposal. Yeah. So this is the slide. I think when we were not pre-COVID, 2019, Seaward Medical Association functions occur at HN Reliance every month. And one of the talk was on stroke. And this is the slide I had presented that future of stroke therapy care will be use of artificial intelligence to predict stroke outcome and decide the therapy. And that probably, we must say, that has come true, and that's what we are doing these days. So this is what I'm going to emphasize in my talk. So this is just the outline. We'll not waste time on the outline and go to the first slide. So as you know, the time is brain still continues to be a paradigm, particularly when you have patients coming within the first 4.5 to 6 hours with acute stroke. And these are the guidelines as of 2018, which says that patient with acute stroke within the first window period of 4.5 hours must be evaluated and then treated as early as possible after ruling out intracerebral hemorrhage and trying to do appropriate imaging, which I'll focus on, and then treat it with either injection actylizer as before, and of course now, of course, we have another agent, tenecteplase, which has been found equally effective, and that's what we have been, our at this protocol at Reliance Hospital has changed to using tenecteplase in acute stroke. So that is how time bound. So a person who comes to you in stroke, time is brain still holds true, and that's what we follow. And why do we do that? Because as you see this, we should get familiar with few terms here. We have to get familiar with the term of ischemic core and and penumbra. So the penumbra, or the area of the brain which is salvageable, is probably there is a dynamic pathophysiological process going on in the brain, and probably it's a time-bound thing, and it keeps on changing from time to time. As you say, the penumbra is the area of the brain where there is less circulation, but circulation is still enough so that the brain is, though it is not functional, it is still salvageable. And the whole treatment of acute stroke relies on this penumbra. That is, you reperfuse the brain so that the penumbra remains alive and you salvage that tissue, and only the core tissue probably you lose. And that's the whole treatment of acute ischemic stroke, which holds around on the concept of this. So however, time is brain holds true is again shown by this graph. This is a whole patients where mechanical thrombectomy or you reperfuse the brain. And as you will see, every 30 minutes delay in reperfusion leads to reduced 10% reduction in good outcome. So good outcome meaning, what we mean by good outcome is the person who goes to society and becomes as normal as possible. That is modified Rankin scale 2. So if you want to achieve that, you have to move as early as possible. So this is all the premises of time is brain is, and this still holds true in every stroke patients, and particularly in stroke patients who are coming in the first 4.5 to 6 hours. Then, of course, as you know, the era of mechanical thrombectomy came in 2018 after a series of trials in 2015 showed that going there and retrieving the clot and recanalizing and reperfusing the brain is possible, and it is evidence-based, and that's how the guidelines were given to people who have probably acute stroke coming to us within the 6 hours. You analyze their, see if they have a large vessel occlusion like middle cerebral artery occlusion or internal carotid occlusion, and subject them to interventional therapy, and that's the guidelines came in 2018. And of course, later on, in the 18, there are 3 things happened in 2008, 17, 18, that we had window period was extended by studies which showed that some of the patient, if you use the imaging methods and show that they have a salvageable brain tissue, you can use intravenous thrombolysis to treat them with successful results. And similarly, we had new 2 studies, landmark studies like DAWN and DIFFUSE, which showed that by using neuroimaging methods, you can again use your extend your window period to almost 24 hours. And these 2 new things happened. And this was, of course, based on the advances in neuroimaging, and that's why the title that our paradigm shift is from time is brain to neuroimaging brain, because you know to understand tissue is what is the level of tissue, and this is what RAPID does. It shows this. I'll go into these details. I'll not waste time on this slide. And then the guidelines were revised again in 2018, that you have people, you can go up to 6 to 24 hours if you use CT perfusion methods or automated analysis of all the data obtained on CT perfusion, and say that the person is in window period. You can use it and go in for mechanical thrombectomy even up to about 24 hours and 16 hours. And that's what the guideline was again changed in 2018. So this slide is not complicated, but just to show only the point which is shown here is that whenever we use this, sorry. Oh. It's not working. Okay, sorry. The mouse is working. Anyway, just the point is, if you go through all the bar diagrams in the last 2, clinical mismatch group and target perfusion mismatch group, these are the groups where the best outcome as compared to undetermined profile. So by using this profile of neuroimaging methods, you can probably highlight patients who have mismatch and select them for particular intervention. They do better than people who did not have mismatch. And this is what, if you analyze all the data of mechanical thrombectomy, the conclusion will come to that. So when you see a patient of acute stroke, the quick questions we need to answer: is there a hemorrhage? Is a major artery occluded? What part of the brain is irreversibly injured? That is the ischemic core. And finally, is there a penumbra? And these are the 4 questions we need to answer in every stroke patients. If you are in window period of first 4 hours, you need to answer only the first 2 questions and maybe third questions little bit. And this is what one who's neuroimaging shows us. Probably will not go into this slide again. So if you take a patient of acute stroke, as we comes to HN hospital ER, immediately they are moved to CT scan, and if CT shows this, then of course he has a hemorrhagic stroke, and we did not go to further stroke protocol, except for the hemorrhage protocol. Then we look for hypotensity and then aspect score we just mentioned. This just tells us the severity of ischemia already occurred. So sometimes patients come to us within 1 hour also, they already have hypotensities, which is almost 2/3. And these are the bad patients. Even if you do intervention, they are not going to do very well. So CT scan is done also to characterize what is their aspect score. That is score which is basically used only for middle cerebral artery strokes, and they have 2 slices of the ganglion level and the supraganglionic level, and we mark them. If the areas which I have shown, if they are hypotense, then probably you keep on deleting points from that 10 points. So normal score, if a CT is normal, it is 10. If a patient has severe stroke, it will be 0. So sometimes we also look for obvious evidence of large artery occlusion, such as hyperdense artery, which is shown here. And of course, in the CT, you can also in the first 4.5 hours also undergo CT angio, and you can show whether the major artery is occluded or not. So CT-based technology, if you do all this, in the first 4.5 hours suffices, and you can treat your patients accordingly. But when you come to after 4.5 hours to 6 hours, then we have to use the automated perfusion scan. So rapid automated perfusion scan is a software which probably analyzes our data and gives us idea as to whether the person has reversible, what is his core area and what is his penumbra, what is the perfusion level, and probably also gives us idea about whether the major artery is occluded or not. And this is what helps differentiating those with or without salvageable brain tissue. And I'll just show you some examples of that. The important thing to remember that if this is the graph which I have shown here, I don't think they have a pointer, so come on. So it shows here that if you see this figure there, if a person has middle cerebral artery occluded, the clinical syndrome or the size of infarct will vary from person to person. Almost about 30% of patients will have full size, that is almost 370 ml of infarct within about 1 hour or so. While others, some of them will not have big infarct till about 12 hours. So by extending your time window period, what we are trying to do is trying to catch all those patients who have a slow progression. Why the progression is slow? Because of the simple reason that the collateral is good. So even though major artery is occluded, there is a collateral flow, and person keeps on have survival tissue even up to 12 hours. So if you treat them even at 12 hours, they may do very well. While those about 20-30% who have massive infarcts within 1 or 2 hours, even if you do best cure, probably it cannot give you good results. And that is why we require CT perfusion after about 4 and 5 hours to decide whether he has a salvageable brain tissue or not. So this is the, again, EVT results, that endovascular therapy results of various trials. And what I have done there is marked arrows. Those are the arrows where the difference between the non-intervention group and intervention group is so marked. And these are the trials which used rapid perfusion automated these to select their patients. So if you use this method to select the patients, your outcome improves. So this is the software where probably in a nutshell what it does is you have a CT or MRI based technique. You can put your patient on CT or MRI, do their plain CT or MRI, give them a bolus of contrast material, and then scan them in two slabs, and those scans are transmitted to the server, and server probably within 5 minutes or so they analyze the data and give us maps of what is happening, and those maps come there. So this is the method which I just already mentioned, so we'll not waste time on that. And this is what we get. When you get a map, you get graphs which are, if you see here, there's a pink shadow and there is a green shadow. The pink shadow is the infarct core. That is, that area is already damaged or is dead. While the green shadow is the area of brain which is hypoperfused, but in some of the area is salvageable. So when we look at the patients, we look at whether there is what is the difference between the pink shadow and the map dot is a green shadow. So if there is a difference of them is very significant, then we say that the person is has a significant salvageable brain tissue and you should go further for the treatment plan. So every patient, this can be obtained within about 10 minutes if you do a CT, and maybe if you do MR, it will take a little longer time. So this is just a case example. This is a patient who has, so this patient has, if you see CT perfusion on the left upper side, you can see a right MCS stroke where the pink shadow is there, and you have a green shadow which is a much larger area. So there is a difference, significant difference, and what we calculate is a target tissue mismatch ratio. So that mismatch ratio is a perfusion area divided by the core area. So anything which is above 1.8 tells us that the person has good chance of going probably salvaging the brain tissue. And so this man, we underwent a successful right intercarotid angioplasty and right MCA thrombectomy. And if you see the last is a MRI brain which shows final area of damage which is very related to posterior parietal area. So same thing is second patient. Also successful MRI, if you see the diffusion in the last slide shows an area of brain damage which is much lesser than the green area. So successful reperfusion leads to this kind of salvaging of brain tissue. But in this patient, unfortunately, thrombectomy did not succeed. So that's why the area of infarct now on the last slide on the diffusion in the lower cut is much bigger and almost similar to the perfusion abnormalities. So you could not salvage this person, but the previous two patients could be salvaged on the basis of diffusion and perfusion MRI. So summary, this is what I think you should remember now. Total hypoperfusion brain volume is the volume of the brain with Tmax more than 6 seconds equivalent to infarct core. Infarct core volume is the area of the brain which is the cerebral blood flow is reduced less than 30%. That is mapped out by the rapid software, and penumbra volume is the volume which is hypoperfused brain volume without minus the infarct core volume. And these data are available to us on the rapid scan. You can decide. This is one recent patient, which this is how the message we get on the scan. This is a patient who had come to us with the right MCS stroke. If you see, there is core volume is 0, where there is a huge area of green damage, which is hypoperfused area, and then you had a right MCA which was blocked. And this is what the message came to us: is thrombectomy may be indicated if patient is eligible. So this is how we get a result within about 5 minutes in the rapid software, and we can then take a decision whether the patient is eligible or not, and go on to do remaining therapy and call our intervention person Nishant and look after. This is what we did, but fortunately we had used tenecteplase in this lady. The tenecteplase already opened up the vessel, so when we did a DSA, the artery was already open, and we did not have to do any mechanical thrombectomy. So why imaging selection is required? There are only 3 points which are summarized here. One is, of course, to give appropriately and to avoid futile thrombectomy. So if you already have a person who is infarct core and perfusion area almost matching, and the ratio, that is target mismatch ratio, is less than 1.8, you may not do thrombectomy, because there the reperfusion will be futile. Not only futile, it will be risky, because when you reperfuse the brain which is already necrosed, it will bleed and lead to intracerebral hemorrhage.
2 minutes.
So this is the workflow we follow. I think this is what most of the thing I have summarized, so I'll just go into 2 cases. So this is the one case which is about employee's father was brought to us within about dysphagia and right hemiparesis. Within half an hour prior to arrival, his BP was normal, his saturation was normal, he has global aphasia, right field defect, dense hemiparesis. His NIHS stroke, National Institute of Stroke scale, was 18. That means he had a big stroke. His CT brain aspect score was 6, so his brain damage was not that much on hypodensity. And so we probably, even before interacting the contrast, we went ahead and thrombolized him with tenecteplase. We started, as I told you, tenecteplase is equally useful and it saves money. So now we have changed our protocol to use tenecteplase, and CT perfusion and CT was also done. So door to needle time, if you see, is only 24 minutes. So by the time he arrives in this, we did it almost 24 minutes, we could do it. So I just managed to spend time to just mention that, but since there was less time, I will not go into this cell. This is the gentleman. Of course, when we did the CTA, it showed again the left MCA was occluded. Dr. Nishant was called in. this is what it shows. There is definite target mismatch. If the core, if you see the core, there is hardly anything seen, but there's a huge area of brain damage on the left hemisphere, which is likely to be hypoperfused, and this is probably salvageable, and that's what he underwent intervention. The MCA was opened up. If you see the left side, the MCA is blocked. The right side image shows that it is opened up, and thrombus was removed, and he completely improved, and probably the CT scan shows no infarct, and he was discharged. So the second patient, I think, we'll skip, and we'll just, because we have 2 minutes, we'll just go to the last message. I think Nishant is going to show some cases anyway. Yeah. So this summary of talk is here. The time is brain continues to be an important factor in managing stroke. Since therapeutic window of salvaging brain tissue may vary from person to person for the reasons which I already showed, we need tissue window, the physiology window. And the introduction of perfusion imaging now, it is possible to study the evolution of ischemic penumbra and treat patients especially in late window time, that is beyond 4.5 hours and 6 hours. So even if you see the patient late, make sure he still goes to appropriate center. Intravenous thrombolysis can be done up to 9 hours if you use all these techniques, and it can, the EVT, endovascular therapy, can be given up to about 24 hours or even beyond sometimes. The rapid software allows us to study all the parameters in the matter of few minutes, and this has been validated in various well-designed studies. So that's why imaging is brain. And then, of course, my last slide, getting to the right place at the right time can be tough, as shown here. And thank you for attention. So please direct your patient at a proper stroke-ready hospital. Thank you.
Thank you, Dr. Arun Shah, for a wonderful talk. May I request Dr. Manoj Malkan to please give a token of appreciation to our doctor. I request Dr. Nishant to please look in the meantime. So there's a saying, an apple a day keeps a doctor away. But I think if the doctor is as handsome as you, I would rather keep the apple away. Thank you for giving a wonderful talk. I wish to welcome Dr. Usha Shah, President D Ward. May I request Dr. Bharat Bhatt to please welcome Dr. Usha Shah, President D Ward. Thank you, Dr. Usha, and thank you.
Opportunity to talk. And Sunday without mask after COVID is really refreshing to see all of you. This is the time in stroke management also I come, like first imaging is done, then neurology team, search team sees, and then I appear out of nowhere. And everything is done, means I hardly do anything, just go and take the clot out. This is what I need to do, and this is what I meant to do. And this morning also, before we started, we had a conversation, me and sir, that there is a stroke. So what will be more fitting than this, that we are starting a stroke talk and we are getting a patient. And this is how it is. And this is going to be more and more prevalent and more frequent, because we are hardly doing any stroke numbers for this population of Greater Mumbai and Mumbai per se. So as sir already had talked, now the old adage of time is brain is converted to penumbra is the brain, or imaging is the brain. If we diagnose a penumbra, a salvageable tissue, and as sir has mentioned, futile thrombectomies, if there is a infarction already established, there is no need to do thrombectomy. Reverse is true, even patient is coming after 36 hours, and there is a penumbra, we should go and open the occluded vessel, because these patients are surviving on the collaterals. And that is the theme. If you want to take one message, don't consider time as a factor for stroke treatment, as a stroke management. Think that if salvageable brain is there, go ahead with the revascularization, whichever way. So this is how it is nowadays. And this is where we work. These are the systems we work under roadmap to go as far as distal in the blood vessel of the brain. And as sir mentioned, we should err on the side of investigation. If somebody has suffered a stroke, even MRI angiography comes normal. Nothing to worry about. What we are going to lose? Nothing. Hardly any resources are wasted. So err on the side of more investigation rather than no investigation. And we should attempt to take care of patient in a center which is stroke ready. Now more than stroke ready, now we are a stroke sensitive hospital. Imagine at 1 o'clock midnight, a patient is coming and he's wasting half an hour for the billing clearance. Is wasted, stroke is wasted there. The penumbra is wasted. So it should be a stroke ready hospital and it should be a stroke sensitive hospital. More and more we do these intervention in one particular center, better we are becoming. And it's not my expertise. It's just the logistics, how we are placing our logistics around a stroke care. So these are some of the systems we use. It's called road mapping. And in a very short duration from 2014, by 2017, we had a 1A evidence. Extremely rare in medicine to have this kind of data. And number needed to treat for stroke is approximately 2.7. Is amazing. It never been seen, never been witnessed in clinical medicine. That in such a short duration, we got such a huge amount of data in favor of thrombectomy for a stroke. And this is what I'm talking about. For out of the window period, still we are in 2A, but for within the window period, 6 hours, we are still 1A evidence, which is phenomenal. Just I will walk through you some of the images. It's like 1,000 words. And this slide is just all about the age. 86-year lady fit, taking everyday morning and evening walk, had this dominant hemisphere stroke, very high stroke scale. And this is MRI we got. You can see there is a very early change of diffusion weighted defect. You can see on the left side, those early white changes are the area which is at risk. And what we got here is the occlusion of middle cerebral artery. You can see the stump. And with this kind of imaging, my half road mapping is done. What I'm going to do, what I'm going to use, what will be my access. So from the arch of aorta to the brain, I'm having full roadmap before I venture into the thrombectomy. And this is what we found out, that there is occlusion of middle cerebral artery. And there are two ways to treat it. One, to just aspirate the clot, and second is to hook the clot and bring it out. So on the top is a stent retriever and lower down the large bore catheters. And this is how the Solitaire or any thrombectomy device, there are too many Catch Maxi, Solitaire, all these devices are made to, on the same principle, to hook the clot and bring it out from the circulation. And this is another system, it's called penumbra system, which aspirate the clot with a large bore catheter. It is 6 French large bore catheter going into middle cerebral artery. It's amazing. 5 years ago, nobody would have thought that a 6 French will go into middle cerebral artery. And this is how we started. All the discussion and everything is done. Earlier it used to take some time. Nowadays it is standard care, so no time wasted. And this is the large bore catheter. You can see bending into the middle cerebral artery. You can see the marker and just above the left orbit. And this is the thrombus. And you can see the left side of thrombus is exactly like the large bore catheter where it was hooked and removed. And this is after thrombectomy. Nobody can believe that this was occluded 10 minutes ago, and arteries are absolutely normal in an 86-year lady who had a dominant hemisphere symptom. And this is pre and post to see, is completely recanalized. It's called Tiki 3 flow. This is the holy grail of any stroke treatment. When you get all the vessel occluded earlier and you open completely, there is not even a small amount of thrombus in the distal circulation. That is called Tiki 3. And this is the most satisfying result you get. The most important, the gaze paresis, gaze palsy improves on the table as soon as you have a successful recanalization. And power, by midnight she was virtually normal except very small slurring of speech. And by morning, normal. Discharge on day 5. In an 86-year, a fit person is far better than a 35-year diabetic, hypertensive, stress-related job. So this is what we are now venturing into, 6 to 24 hours thrombectomies, given that there is a penumbra. And as we have discussed earlier, we are having a very significant healthy data for evidence-based medicine to go and do the thrombectomy for beyond window period. So this is one of the such case, 73-year lady with atrial fibrillation history had this stroke. Another large vessel occlusion. You can see on your bottom, there is no carotid on this side. This was the time when the data of down and diffuse are getting collected. So there was a discussion. We discussed. By the time MRI finished, she virtually recovered completely. Again, this was the time when the down and diffuse data was not consolidated. So we conserved at that time. By 10 a.m. next morning, she was back to square one, even worse. Completely hemiplegic and aphakic. And this is the imaging. If you see, there is hardly any damage on the left side of the hemisphere, but her symptoms were too much. So there is a clinical radiological mismatch. This was the time when the rapid was just in foray. It was not completing to the clinical practice. So we used to do this mismatch. So even now, we can do this mismatch. If there is radiological small infarction and the clinical severity is far high, that means there is a penumbra, there is a salvageable tissue. And this is what we have used. There is not much damage, so thrombectomy is indicated. It's just to compare pre-midnight and 10 a.m. MRI, there is not much of difference, just maturation of infarct. And this is what we found out. This is internal carotid artery occluded in the neck. And there is some collateral from the right side, but certainly it is not sufficient. That's why she is hemiplegic. And to start, we aspirate the thrombus first in the neck, large load because of atrial fibrillation. And then we recanalize the carotid artery in the neck, but you can see there is no intracranial circulation. So standard care, you go distal and put with aspiration, we put another stent retriever to bring the thrombus out. And same result. Underlying disease removed, the thrombus removed, artery is absolutely normal underlying, there is no atherosclerotic disease. Just to compare pre and post, pre, first recanalization and full recanalization. Same story with all atrial fibrillation. Because of the size of the clot and the recanalization we achieve in TICI 3, they recover beautifully over next 24-48 hours. And this is what she did. And next day MRI, hardly any progression of damage. You can see very small spot in the posterior parietal area. Otherwise, it's absolutely same. Over next 4 days, she recovered completely. And this is the next day CT. On right side is the old stroke she suffered 5 years ago. We are talking about the left brain, which is absolutely normal, except very small damage in the peri-sylvian cortex. By day 7, in all these patients, we'll do a TE to see the thrombus in the cardiac chamber. Nothing was found.
2 minutes.
And this is the data we collected over the out of the window period. Now this data is approximately 35 patients and very good results. So this is now the frontier, large core thrombectomy, where we diagnose that this is a large core. Still we do the thrombectomy because if patient come in the early part of the window period, same lady, 70-year lady, large infarct. 2 years ago, we would have said, no, nothing can be done. But in her case, we removed the thrombus, TICI 3 flow, large infarction on day 1 CT scan. But look at the progression of, her clinical progression was far better than what we saw on imaging. And more than that, day 9 CT is not as bad as the day 1 CT. So these are the things we are in the process, it's a work in progress. But we are doing now large thrombectomy where the established infarct is seen and patient is coming very early in the window period. And this is to compare first day and day 9 CT scan. Good amount of tissue was salvaged, and by 3 or 4 months, she's on MRS 3. She utters few words, and it's good. So take home message, time saved, brain saved, it always will remain same. Go to a stroke sensitive, stroke ready hospital. Out of window stroke thrombectomy is needed when we can diagnose a penumbra by rapid or whatever means we have. enlarged court thrombectomy is frontier, where earlier we have given up that nothing can be done. Thank you for your attention.
Thank you, Dr. Nishant, for a wonderful talk. May I request Dr. Jawahar Mukhtiar to give him a token of appreciation. As we are moving forward for our inauguration ceremony,
We have 2 cables, but it's not working there.
I request Dr. Anil Mehta to please welcome Dr.